Yeah, good evening, everybody. We
Yeah,
have Dr. Adil Beigh, and we are proud to say that sir was part of these DNB classes and now based at Srinagar and a big known name in interventional nephrology. Uh, so, sir, the stage is all yours, sir.
thank you. Thank you. Oh, uh, Good evening, everybody. I'm Dr. Aadil Beigh. I'm a full-time intervention nephrologist, and I also see kidney transplant patients. I also see, but I'm forced to see the general nephrology, core nephrology patients. Uh, Intervention nephrology is very interesting branch, and where you can help the patient. You can you have a disease excess, you have a malfunction excess, you correct it, and on the same day, after the procedure, you can send him for the dialysis. So there is less uh, missed dialysis sessions. There is less emergent conditions. There is less temporary lines, less sperm cats. So that way you can save the patient, and you diagnose the lesions early, very early, by short physical examination. So today's topic is physical examination and surveillance of the hemodialysis excess. So what we should do that it should be 10-second examination, and by those 10-second examination, we should get all the information. By touching the AV fistula, we should know what is the problem. That is the actually the examination. It gives the information. It gives the 95% information that the where is the lesion and what should be the line of action. So we'll go through the physical examination. It's the old presentation what I have made while I was doing my intervention nephrology training in CMC Vellore. So it's the same slide. So the what is the learning objectives for today that we'll go for the basics of the physical examination. How should we examine the axis? And what are the basic manuals that there are 2 3 manuals what we should look for the outflow track, inflow track of the AV fistula, and the specific examination in pre and post access placement. And then we have an interaction later on for better understanding. If you have some problems, then you can doubts, then you can ask me. And what this learning will add to our knowledge that we can describe the findings of the physical findings, that inflow, how is inflow, is it working correctly, is there problem in inflow, is there problem in outflow, is there problem in juxtaosmotic site, is there problem in fish body of AV fistula, where is the stenosis. We can get those information by discussing. After discussing these things, we can get all these things to know where is the problem. So in the uh, so there's a basics of the basic aspects of the physical examination of the AV fistula that we should look at the fistula, we should feel it, and we should listen. There is something in the fistula: pulse, thrill, and bruit. We'll see. We'll discuss those things. And in visual inspection, we can see the signs of hand ischemia, swelling, edema, induration, aneurysms, bulbs, other things, and the infection also. So remember, there is pulse is abnormal for the fistula. If there's a pulse, that means there's a problem. There is no pulse in the fistula. Never. If fistula has, it's a high flow fistula, it has a little pulse. It's compressible, it's soft. If fistula is not soft, it's not compressible. You're putting hand on the fistula. There's a pulse. There's a no flow going in the diastole, there is flow going in the systole only, there's a pulse style fistula, that means there's a problem. So pulse in fistula always a problem. We should go for the Doppler at least. If not, go for the fistulography, angiography, go for the Doppler. It is mandatory. So because there is no pulse in the fistula. If there's a pulse, it is very soft pulse. It's very little pulse. So then, if you feel the fistula with the palm, so you can feel there's a vibration, the palpable vibration is a thrill. It is always soft. It is diffuse. You cannot feel that this thrill is coming from this segment here. So it's diffuse thrill. It's a continuous thrill. There's a thrill in the diastole. There's a thrill in the systole. So it's a machinery like it is going. There's a like things. There's a like the machinery murmur in PDA. So if there is a systolic thrill, that means there is something, some resistance ahead. If there is a loss of thrill and there is appearance of pulse, there is no thrill, only pulse. That means the stenotic lesion is very tight. So systolic thrill abnormal, pulse abnormal, soft thrill in the diastole, in the systole is normal fistula. So same thing in the bruit. It's a continuous diffuse rumbling sound. But the thrill, you feel that you listen through the stethoscope. So it's low pitched. It is best heard at the anastomosis. And if there's a systolic component only, there's a problem. Something is there. So when you get the pulse, when you get the systolic thrill, when you get the systolic bruit, that means you have to go for you have to advise the patient that there is something, some problem with the fistula. You can correlate with the venous pressures, other things, and you have to go for the Doppler. Or if you are doing Doppler yourself, you have to look for the stenosis. There will be some stenosis, some amount of stenosis. If there's a strong pulse, that means there's a very tight stenosis, strong thrill. There's no thrill, and the appearance of pulse, that means there's some uh, very tight stenosis. So there are basic manuals for the inflow and the outflow. And the arm elevation, when we tell the patient to elevate the arm, so there is a flaccidity of the fistula. The fistula it dips, and it says that there's a outflow is okay. So, for example, there's a fistula, radiocephalic fistula. It has an outflow. It can have an outflow from the basalic vein of the arm. At elbow, it can have a basalic vein, or it can go. Its outflow may be the cephalic vein of the arm. So if there is a stenosis of cephalic vein or the basalic vein of the arm, though there will be so the outflow means there's a outflow is obstructed. If you raise the arm of the patient above the heart level, so it will not collapse. When it collapses, or there's a mid-body stenosis, so the initial part from the anastomosis to that stenotic part, it will not collapse. Beyond that stenotic part, it will collapse. So it will give the exact location of the stenosis. Like this patient, say I'm raising his arm above the heart, so it gets collapsed. Both of the aneurysmal sites, it's an overutilization of the segment, there's aneurysmal dilatation, but they are flaccid, they dip actually after elevating the arm. That means there is no stenosis here, then there's no stenosis outflow. So like this, so when there's an anastomosis and there's the patent vein, and with the patent outflow, when you raise the arm, there's a collapse of fistula. And if there's a mid-body stenosis or the outflow stenosis, so this fistula remains distended. So, beyond the stenosis, it remains distended, and then the outflow vein, it gets collapsed. So pulse augmentation is for the inflow. So inflow is considered so there's a fistula. So there's a fistula, there's a artery, there's a fistula, there's a proximal part of artery, there's a distal part of artery, and there's an anastomosis. Proximal part, distal part, anastomosis, and the first 2-3 centimeters. There's a debate. Some says 4, some says 5, some says 6, some says 2, but generally 2 to 4 centimeters from the anastomosis is considered as juxtaanastomotic segment. So juxtaanastomotic segment inflow is inflow, considered as inflow, anastomosis inflow, proximal artery inflow, distal artery inflow. If there is a problem with the distal artery, there will be low flow, less flow in case of radiocephalic fistula, because radiocephalic fistula gets flow from the ulnar artery also. So retrograde ulnar artery and antegrade radial artery. So from the radial artery, from the ulnar artery, so the distal part of the radial artery gets flow from the ulnar artery. If this is occluded, there will be less flow to the fistula. If the proximal part is occluded, so less flow. So that there is something known as clamp stenosis. We clamp the distal and the radial, the proximal part of the artery, and after creation, sometimes there's an injury and you get the stenosis of the distal or proximal part of the artery. So if there is a stenosis of those segments, there will be the less flow to the anastomotic side and the fistula. If there's a problem, there's an anastomotic segment. Anastomosis is stenotic. You have given the only 2 or 3 mm of the anastomosis, this arteriotomy. So there will be stenosis, or there's a tight stitching, other things, calcium deposition, or there's an intimal hyperplasia of that segment. So something is there. So it causes the stenosis of the anastomosis. And if there's a juxtaanastomotic segment stenosis. So this is considered as inflow. So when there's a inflow problem, that means less flow is coming from the artery, or the flow is coming from the artery. It's not reflected going through the anastomosis, or if the anastomosis is okay, it's not going to the juxtaanastomotic segment, or it's going through the anastomotic segment, but the flow is less. So when we occlude the access at some distance from the anastomosis, for example, there's a 10 segment of anastomotic, this segment of the vein at 8 centimeters where we are occluding. So there will be the loss of thrill. First thing what happens, when you feel there's a thrill. So when there's a loss of thrill, there's an appearance of pulse, because we have occluded the segment. And the pulse intensity tells you the how much flow is coming from the inflow. If the strong pulse, that means inflow is very good. There's arteries, distal, proximal, and anastomosis, and the juxtaanastomotic site is very good. If the pulse intensity is very less, that means there's a less flow coming from the inflow. So that means that there is a problem with the inflow. So we have to go for the angiography. In angiography, from the radial artery or from the fistula, we can see the distal part of the radial artery, or the brachial artery, proximal part, anastomosis, and the juxtaanastomotic segment. So when there is no pulse augmentation, that means there's a lesion in the inflow. When there's on arm elevation, there is no fistula is not collapsible. That means there's an outflow stenosis either in mid body or in the outflow. So it's like this. When you occlude the segment, and there is when you palpate this, there's an appearance of pulse, and the intensity of pulse will tell you how much patency is of proximal, distal, anastomosis, and juxtaanastomotic segment. So when we go for the placement of the access, how we evaluate for that? So patient comes for the access creation. For example, patient comes from AV graft or AV fistula. How we evaluate those patients? The patient comes for, after the creation of fistula, he says, I have created the fistula 3 months back, but still it's not working. There is no 2-needle successful cannulation of this fistula. That means there's a maturation of fistula. That is non-maturation of fistula. how we examine the non-maturation and what are the causes of those things, and what are the evaluation, how we evaluate the mature access. The patient is there, he is on dialysis, he has successful two needle cannulation, and how will you access those fistulas? So there are three things. Then the pre-evaluation, evaluation of non-mature fistula and the causes of that, and the evaluation of the mature fistula. So prior to the access creation, we should go for the arterial evaluation. This is very, very important. It's nothing. You have to put the, you have to see the arteries, radial artery, ulnar artery, brachial artery. Yes, this is the normal, this is 2 plus, this is a bounding pulse, this is diminished pulse, there is no pulse, and no pulse, you will evaluate accordingly. There is diminished pulse, you will evaluate accordingly, and there's a normal pulse, no need to evaluate for that. On Doppler, you can see the size of artery, other things, peak systolic velocity. And diminished pulse, there may be the problem with this peripheral arterial disease may be there. There will be calcification, diabetics, old age. There are a lot of patients of those. So you have to evaluate those things. And simultaneous BP monitoring in both arms within minutes. So within 4 or 5 minutes, you have to see both the BP because it fluctuates. If it is difference is less than 10 mmHg, it's okay. 10 to 20, this is marginal. You can go plus minus after seeing the Doppler peak systolic velocity is okay. There is no subclavian other artery stenosis. It appears that there's a mild or moderate calcification. You can go for the fistula creation. And if it is more than 20 mmHg, never go for the fistula before evaluating the arterial system. So there is known as modified Allen test. So what is actually the modification? Why it's called as modified Allen's test? So in Allen's test, basically we determine the radial artery, only radial artery. But in modified Allen test, we determine both the competency of the radial and the ulnar artery. So when we put a pressure on the ulnar and the radial artery, and ask the patient to clench his fist, to make a fist, and after making a fist, there's a blanching of the hand, and we remove the pressure over the radial artery, and there is the perfusion of the hand. When the perfusion of hand occurs within 5 seconds, that means it's negative. When 5 to 10 seconds it takes for the perfusion, it's intermediate. We can go for the arterial Doppler and other things. And if it is more than 10 seconds, you have to go for the arterial examination, the angiography and other things. But when it is the 5 to 10 seconds, you can go to palmar arch ultrasound. You put a Doppler on the palmar arch. You see the peak systolic velocity of the palmar arch, peak systolic velocity ulnar artery, radial artery. See the degree of the calcification. See the hyperemia. We can discuss it in the ultrasound. Hyperemia of the this uh, after after making a fist, releasing a fist, see how much blood is going to the palmar arch. If there is if it is okay, then you can create a fistula. If it is more than 10 seconds, then you should not go for the fistula creation. Same for the ulnar artery, we should do the examination. This is the superficial arch, this is the deep arch. So we can see the patency by blocking this and the radial and the ulnar artery. So it is further modified with the pulse oximeter. When there's a, you have put the pulse oximeter, you can see there's a normal wave flow. When you put the compression on the radial and the ulnar artery, there's no flow. So you release the pressure on the ulnar artery, there will be the normal flow. So that means the ulnar artery is patent. When there's a no flow, then that means something with the ulnar artery, it's partially or the totally occluded. And if you release the, after doing same thing, the compression of the this radial artery, ulnar artery, again you release the radial artery, so there will be normal flow. That means the radial artery is patent. If there is no flow or the less flow, that means the radial artery is obstructed. So there should be at least 2 mm of the arterial size for the creation of AV fistula. When you see with the Doppler, there should be 2 mm, the inner diameter. Intimal to intimal diameter should be 2 mm. But it's not validated. Why? Because a lot of studies show that what actually happening when there is a 1.5, 1.6 diameter of the arterial diameter is there in a diameter, and there is a success rate is around 70 to 80%. So that means the arterial size should be at least 1.6 centimeters, 1.66 mm. So ideally it should be 2 mm. So for the venous evaluation, we can go for the physical examination, we can go for the vein mapping, we can go for the color Doppler, and then the venography. If there's a confusion in the, so you can see the intimal hyperplasia, then you can have the color flow, venography. You have a confusion in the ultrasonography, go for the venography. You have to put the angiocath in the dorsal of the hand and go for the angiography. You see the veins of the hand, this forearm and the arm. So this is the venous mapping. You can see the vein, you can see the cephalic vein arising from the wrist. Then another vein is joining here from the cephalic vein. Then cephalic vein breaks down, goes to the there's a median cubital vein. This is the basalic vein, and it can form the cephalic vein of the arm. So you can see the basalic system also. So the luminal diameter should of the vein should be 2.5 mm or the greater at the where you want to have the anastomosis. So when you have more than 2.5 mm, the chances of fistula maturation is very high. There should be no absence, there should be no obstruction or thrombosis of the vein. There should be straight 10 centimeter segment of the vein, and it should be less than within the surface, 1 centimeter within the surface, and it should continue with the proximal veins of the body. So, for example, this is the angiography. It is showing the cephalic vein of the forearm, basalic vein of the forearm. There's a median cubital vein, and the cephalic vein is running and going as a basalic vein. Then again, one branch is forming the deep vein from the deep system is median cubital vein. This vein is joined by this vein and forms the cephalic vein of the arm. So this is the basalic vein. Then with the this cephalic vein forming the cephalic arch, and then it is joined by this basalic vein forms the axillary vein forms the subclavian vein. So same thing, like left this is the axillary vein. Axillary vein is joined by the cephalic arch, forms the subclavian vein, is joined by the internal jugular vein, forms the brachiocephalic vein. Opposite brachiocephalic vein joins from the superior forms the superior vena cava. So you can evaluate with the angio all the veins, the obstruction, other things. You can see there's a something in the axillary vein. You can see. So you can go for the venography. You have to go for the Doppler ultrasound. Doppler ultrasound is very, very important. Or you can have the examinations. The lot of surgeons they go only with this or a nephrologist they go with the examination only, but what we have seen or what all the studies have seen that the Doppler gives you the insight of the vascular system. So you have the placement of the AV fistula. So what are the causes of the non-maturation of the fistula? So the commonest cause is inflow stenosis. So in inflow stenosis particularly is the juxtaanastomotic stenosis. For radiocephalic fistula, you should remember this. For radiocephalic fistula, there is the stenosis is juxtaanastomotic stenosis. For brachiocephalic fistula, it is cephalic arch. And for the brachiobasalic fistula, it is swing segment. Where the swing is there, there's an axillary vein, basalic vein. There's an axillary vein, basalic vein. It goes just while transposing there's a formation of the swing segment. There is more turbulence of that swing segment. So there's a swing stenosis is common for the brachiobasalic. Cephalic arch stenosis is common in brachiocephalic, brachiobasalic swing, brachiocephalic cephalic arch, and the radiocephalic juxtaanastomotic. So when there is a juxtaanastomotic stenosis, around 40 to 60% of non-maturation fistula is cause is juxtanosmotic stenosis or the inflow stenosis. Very less for the arterial system, around 10%, not more than that, even less than that. But 60% juxtanosmotic stenosis and around 15% as accessory vein. For example, there's a single segment and it divides into two or three. So the blood is going to all the three vessels, none of them is matured. So that means, so accessory vein, 75%, 75 to 80% inflow, the 75 to 80% causes for non-maturation of AV fistula juxtanosmotic stenosis plus accessory vein. And around 60% alone is 60 to 70% alone is juxtanosmotic stenosis. So when there's a non-maturation, it should come in your mind that there should be, I have to evaluate for the juxtanosmotic stenosis. So in inflow problems, there will be stenosis, or there's an inadequate feeding artery, arterial anastomosis, juxtanosmotic segment, or the combination will be there. Like this is the artery, distal, proximal, and distal. This is the anastomosis. Anastomosis site is patent. See, if you put the hand on the anastomosis site, there will be hyperpulsatile because there is juxtanosmotic stenosis. There will be no thrill or very less thrill. There will be systolic thrill or there will be only pulse. So if there's a pulse at the anastomosis, and when you put the beyond the finger beyond that, there will be no pulse. There will be sudden decrease in the caliber of the vessel, and there will be the disappearance of pulse and the thrill. And beyond that, there will be the immature, small immature segment. So that means this is the juxtanosmotic stenosis, that the inflow stenosis. So you can see with the angio, you can see the angio, this is a distal, this is a proximal artery is very good. It's well developed. So this is the anastomosis. You put the hand on this finger on this will be the pulsatile. There will be the sudden loss of caliber of the vein. And then again, the caliber of vein will be seen, but with less of thrill and less of flow because of this stenosis. And you can see the distal part of the artery is also stenotic. So you can have the, you can detect the arterial stenosis, can have venous stenosis, evaluation of our infections in the axis. There's a, when the mature axis, you can see there's a arterial stenosis, there's a venous stenosis, you can see the features of infection. There will be the swellings, what we call as aneurysms, pseudoaneurysms, or you can have the evaluation for the ischemia also. So in the body of AVF, what we can have the accessory veins or the stenosis, what we see in the non-maturation of the fistula, one of the cause, that this is the patent fistula. When you put the finger on the fistula and occlude the segment, this segment is occluded. So there is an appearance of pulse and there is a disappearance of the thrill. So the pulse will be strong. If the pulse is strong, good, then there means there's an inflow is okay. And the appearance of pulse means that this segment is patent. When you, and then there's this is the examination for the accessory vein. So when you put again the hand on the anastomosis and occlude this segment, and if there is the accessory vein, so all the flow is going through the accessory vein. So that means there's a persistence of thrill. When you put finger on this segment, there will be the appearance of the pulse and disappearance of thrill. When you put this beyond the accessory vein, when you occlude the segment, there will be the persistence of thrill. Always remember, if there's a persistence of thrill while occluding the outflow, that means there's an accessory vein. So there's always confusion between accessory vein and the collateral. Collateral is always formed. Collateral is always formed when there's a stenosis. Accessory vein is the Actually, basically the vein, when there's a division of the vein, it's not a collateral vein, it's a division of the vein, and the flow is distributed in both veins. Collateral veins is formed when there is a stenosis. So when there is a pulse, you have not occluded the segment. When there is a pulse and there is a you can see the veins along the fistula vein. So that means there are collaterals. That means there is a stenosis. Systolic thrill, systolic bruit, pulse style fistula. That means there is a occluded segment. There is a stenosis. That's why there is a formation of collaterals. When there is a thrill, when there is a thrill and you are occluding the initial segment, there is a loss of thrill, appearance of pulse. That means there's a patent fistula. And when you put you occlude the fistula beyond the accessory vein, there is a persistence of thrill. There is the thrill is not lost and there's a no appearance of pulse. Then it is an accessory vein. So these are some accessory vein photographs. Again, same. So now how we'll evaluate the mature axis. So there's an axis and there's a common things what happens to the axis. There's a commonest thing is there's a venous stenosis, aneurysms, pseudoaneurysms, infections, ischemia. So the arterial stenosis is common because of the aged, but once there's a maturation of the fistula, so these things occur less. So venous system is the commonest thing what happens to the AV fistula. So by pulse augmentation, we can have the inflow examination. By arm raising, we can have the outflow examination. But the significant venous stenosis causes hemodynamic change within the axis. And these changes result in the abnormalities that can be easily detected by physical examination. What we saw. So what actually happens to the fistula when there is a stenosis? So when there is a narrowing of the segment, there is a turbulence of flow. When the turbulence of flow, so more of the injury to that segment. So what happens actually? For example, you consider there is a anastomosis, there is a patent 10 centimeter segment, and then after 10 centimeter segment, there is a stenosis. This stenosis has their own resistance. It has a resistance that when it exceeds the resistance of diastole, when it exceeds the resistance of diastolic pressure. For example, patient is having 140 by 80 of BP. When the resistance of this segment, the 10 centimeter away from the anastomosis segment, there is a narrowing of the fistula vein. So when it exceeds the 80 mmHg, that means there will be no flow in the diastole through this segment. Okay. And what happens? There is only systolic thrill. There will be thrill, you will feel the systolic thrill, and will be pulse style, systolic thrill, and there will be no flow in the diastole. When the resistance further increases and it exceeds the resistance, then the systolic pressure, when it exceeds the pressure beyond 140 or it equals to 140, when it goes equals to 140, there is only pulse. There is no thrill. So when it goes beyond 140, the resistance goes beyond 140, there is a still blood goes, there is no blood going from the anastomosis to the from the stenotic site. So there is a stasis of blood in that segment, and there is a formation of thrombus. This is the actual thrombosis formation, how it happens in the axis. So there's a myth that his BP goes down and then he has a problem with the fistula gets thrombosed. It's a myth actually, but it's an immediate effect. So when there's a stenosis, it has exceeded the diastolic pressure. It is almost equals to the systolic pressure. For example, there is a hypotension. There is no flow in the fistula. The little flow what was going in the fistula, it thromboses early, but fistula never thromboses when it is patent. Never ever. Thrombosis of fistula, that means is a dictum, there's a stenosis. Okay, it's like that. This is hyperpulsatile segment. This looks like thrill. There's a systolic thrill only. Localized bruit, high pitch, systolic only. When it exceeds the diastolic pressure, there is a systolic thrill. When it exceeds the systolic pressure, there is no blood going there. There's a stasis of blood and there's a formation of this thrombosis. These are some patients having the no segment here, only this segment, thrombosed part. So the examination of the central vein stenosis, it's very easy. So there is something in the central vein. Yes, we can have a central vein stenosis without history of pacemakers, PIC lines, perm caths, temporary lines, central lines. For example, patient was in ICU somewhere 10 years back. Here's a center line. And then here's a, so these history may be negative. And still you have the ipsilateral arm edema after creation of the fistula. When there's a ipsilateral arm edema after creation of the fistula, that means there's a central vein stenosis. So you have to evaluate for the central vein stenosis. So always pre-examination, ask the patient for the central lines, remote admissions in the ICU. It's a common thing in diabetes, having pneumonia, then the septic shock, A-line history, then the history of central lines. So you have to take the history of central lines. It's not only the pacemaker. Take the history of patient is on chemotherapy, having breast cancer. See the, so you have to go for the, you have to tell the patient that give me the history, past history regarding the pacemaker, regarding the central lines, regarding the perm caths, regarding the temporary lines, regarding the PIC lines, the chemotherapy, other admissions. So this is common. So after creation of the fistula, there is a ipsilateral arm edema. You have to evaluate for the central veins. At times it's massive. You must have seen all have seen probably the same thing. So there are collaterals over arm, over chest. There will be the swelling of the supraclavicular fossa. So you can locate the lesion. Actually, you can locate lesion on the examination. So when there's a swelling of only arm, for example, there's a radiocephalic fistula, and there's a swelling of only arm till elbow. There's a swelling of hand, fingers, forearm, but beyond this cubital fossa, there is no swelling. The arm is flaccid. There is no edema. There is no subcutaneous edema. There is no veins over the chest, neck. So that means the culprit vein is axillary. When there is an axillary vein stenosis, so you will have edema at till elbow. When it goes beyond elbow and around shoulder, beyond elbow, around shoulder, there is a network of collateral veins over the shoulder, not over the chest. So that means it's a subclavian vein. When there's a half of half of the face, that means the forehead. For example, the left side is a half of the forehead, half of the nose, half of the lip, half of the chin, and the half of the chest, upper chest, supraclavicular area, and the arm, whole arm, and the breast. Swelling of the breast, veins over the chest and the breast, this chest and the shoulder, half of the face and the arm. That means this is brachiocephalic. And when the situation is on both the sides, that means superior. So you can localize the lesion, central vein on examination. So these are the some cases. So left brachiocephalic AV fistula. So see the half of the face, the breast, the arm. So this is brachiocephalic, left brachiocephalic. The same thing, same thing. This face, chest, breast, and the brachiocephalic will be the culprit. Both sides. The superior vena cava. So evaluation of the infection, you can see the pus points, you can see the pustules, the oozing of the pus. You can see along the graft there's a cellulites. In the aneurysms, you can see the overutilization of the segment is the commonest cause of the aneurysms overutilization segment with the stenosis. So outflow stenosis with the overutilization of the segment is the commonest cause for the aneurysms. Same thing here. So this is the infected aneurysms. So in the ischemia, you can see the necrosis of the hand. You can have a pale hand, numbness, cold hand. There will be hand pain, off and on dialysis. If it is on dialysis, that means the problem is less. Then it's on and off dialysis, the problem is more. You should evaluate those things. Thank you. Now you can ask any question. Puniji?
Yes, sir. So the students can ask over chat. I think there's already one question, sir, in the chat
Chat
box.
box. Yeah. So where do we keep SpO2 probe while Allen's test? Or the finger. Or the finger, you have to see the blood. If there's a blood flow in the palmar arch, it will go to the radial side. It will go to the ulnar side, both sides. You can have an index finger. So, sir, we can repeat how to evaluate collateral veins. Yeah, for collateral veins, you can have. So, if the collateral veins is the mid arm and the fistula is radiocephalic, and there's a mid forearm collateral. So, if uh, beyond the accessory vein, if you press it, there will be no loss of thrill, no appearance of pulse. So persistence of the thrill will be there. When you go down towards the fistula, when you press the fistula, this vein, there will be the appearance of the thrill, this pulse. So appearance of the pulse, that means the segment has no other collateral, this accessory vein. ठीक? So when there's a persistence of thrill, that means there's an accessory. So collateral vein is always when there's a stenosis. When there's a stenosis, there's a formation of collateral veins. The branches of the vein, they get more blood and they develop, form the collateral veins. When the collaterals, that means it is down. Accessory vein never goes down. Collateral can go down. For example, the collateral is going towards the hand. So there is no natural flow going towards the hand. It will go only up least resistance side. When there's a resistance above, it can go down. So there is a this that way you can say that this is the collateral veins. So inflow stenosis we can have with the when you there's pulse augmentation. When you for example, from the anastomosis 10 centimeter, you just press the fistula vein. If there's a pulse augmentation, that means there's an appearance of pulse, or the pulse is there and it augments, it increases. You can see the pulse style fistula. You can see the pulse style fistula, or you can have augmentation of pulse. You felt the pulse, it is less pulse. When you press this venous segment, there's a more pulse. More pulse means the more flow is going coming from the inflow. That is, the inflow is normal. How to do all central venous stenosis require a stiff guide wire and stent? See, if there's a central venous stenosis, for example, there's an axillary, there's a subclavian, there's a brachiocephalic, there's a superior vena cava, there's a stenosis, you can cross the wire. You can, when you take the angio, At angio, you can see the tightness of the lesion. There can be the complete or chronic total occlusion. You cannot see the vessel beyond the this beyond the stenosis, or you can see the streak of dye going there, or you have a partial stenosis. So it's not always the stiff guide wire. You can do it on the soft guide wire. There's the thermo guide wire. There's a stiff thermo guide wire you can do on that, or you can through the pass the guide wire through the lesion, put it in the inferior vena cava, then uh, that advance the catheter, remove the soft wire, put the stiff wire, and then the balloon also. So it depends, the stiffness of the guide wire depends on the balloon. If you are taking the compliant balloon, soft balloon, Mustang, you don't need this stiff wire. If you are taking the ultra pressure balloon, yes, you may need the stiff guide wire, and not always stent. For example, there's a recurrence of the lesion, there's a recoil of the lesion more than 50%. There's a thrombosis of the segment. You can use the stent, or the patient comes within 3 months. It is repeatedly you are doing the central veins this angioplasty. If it comes more than three times, less than 3 months, you may go for the stent. Could you repeat why was Allen test modified? Because it was modified to check the ulnar artery patency also. Because in early Allen test, it determines only the radial artery. They used to determine only radial artery. When they got to know that the blood is coming from the ulnar artery also to the radiocephalic fistula, that's why the ulnar artery is used to see in the Allen's test. So there is absent thrill in pulse augmentation test. So if there is no augmentation of pulse after uploading the segment, that means there is an inflow problem. So the commonest cause of inflow problem is external stenotic segment, or it may be the anastomosis, it may be the proximal or the distal artery, or sometimes you can have less augmentation in the when there is a severe cardiac this LV dysfunction. Any more questions? USG guided fistuloplasty, yes, we can do it. So the limitation, I have never gone with the, I have done USG guided fistuloplasty, but I have a 24-hour availability of the cath lab, so I don't go for the ultrasound guidance. Ultrasound guidance, you can do it, but it has its own advantage. It doesn't require any cath lab, any specialized this training of the this your assistants. So there is less limitations. So you can go in the procedure room, put the sheath, and on ultrasound see the lesion, put the wire, and on the wire put the advance the catheter, this balloon, and dilate the balloon and see the dilatation of the balloon, and then after deflation and see the recurrence. If there is no recurrence, this no recoil, and there is it is dilated from it was 2 mm, now it is 6 mm, it's okay. So it's very easy, it should be encouraged, but you can not uh, do the angioplasty of central veins with the USG guidance, or with the if there's a swelling of the arm, or if there's a large subcutaneous fat. So those that there's a limitation of the USG guided fistuloplasty. But USG guided fistuloplasty now is taken by everybody because it is less expensive. It costs less. You have to cost a balloon only. You have all we have a procedure rooms. No, don't really need the cath lab also or much of assistance. Any recommendation for AV fistula with distal ischemia? So it depends. It depends. Distal ischemia depends on the condition of the vessel. So if it is brachiocephalic, that means there is a steal phenomenon. So you can have a drill surgery if it is severe. If it is manageable with the drugs, yes, you can. So, and you have to diagnose actually, is it the severe peripheral artery disease or not? You have to See, these things, all these things we can avoid by good examination, pre-assessment examination. What we discussed, an arterial system should be, you have to put the finger on the this artery. Only that thing you have to do. So you can get the all the things. These are all preventable things. When this gets, then you have to other surgeries. You have this their own management. But you should know how to diagnose that. Aspirin, no, there is no role of aspirin. It has never seen that there is a no role of heparin. Some practices that give the heparin during the procedure, 5,000 give subcutaneous. No, all the studies negative for that. All the studies negative for the aspirin. When there's a good flow through the anastomosis, there is no need of anything. It matures itself. No need of exercise, no needs of fist exercise, nothing, no ball, nothing. If it has to get matured, it will mature. If it will not mature, if there's a problem with inflow, it will never mature. So you have to diagnose. Indication for aneurysmal ligation. So aneurysms are not ligated. Uh, for example, there is a pseudoaneurysm. Pseudoaneurysms, you ligate the stump of the pseudoaneurysm. There's a vessel. When there's a vessel, there's a rent in the vessel, and there's a formation of the pseudoaneurysm. So this rent, you just dissect it, you seal the rent, or you can have a fibrin injection, or you can get the stent in the graft stent or the covered stent in the vessel. It will stop the blood flow going through the pseudoaneurysm. When there is a true aneurysm, it should not be ligated. There's an aneurysmorrhaphy. This aneurysm, you cut it, and you cut this part and then join this part. This is known as aneurysmorrhaphy. There is no medical management for the non-maturation of the AV fistula. No. So this is all the mechanical problem. So there's a problem in artery. Maybe there's a thrombus. Yes, you can treat it with the thrombolysis, but it should be acute. But this is a mechanical problem. This most of the things happening to the fistula is treated with the mechanical things. So yes, there's a thrombosis, but thrombosis is the occurrence only secondary to the stenosis. So you have to do the angioplasty and the thrombolysis or thrombectomy. Sometimes you can, if there's an early patient, it's always better. You can, my my unit, we have an, we can try up to 2 weeks. Beyond 2 weeks, there's plus minus. I'll see the if there is some new formation of thrombus, you see, but 2 weeks I take it. Some centers have 4 days. Ames, I was talking yesterday with my friend. He says that will take only for four days, not beyond 4 days. AV fistula surveillance by interval duration. Yes, see, for example, there's a problem with the fistula. So you have corrected the stenosis. You should see it every 3 months. For example, there's a normal fistula. You can see it at 6 months, but you should examine it. The examination surveillance, 10-second examinations is okay. If you feel there is something in this examination, what we discuss, if there is something, go for the surveillance that time. Go for the Doppler. Or at interval, every 6 months, you should go for the fistula, surveillance. Any characteristics on Doppler that will tell this thrombosis will be treated? So thrombosis, beyond that, there will be the stenosis. Okay. So thrombosis, if there is a stenosis, you treat the give the thrombolytic agent, and go for the correction of the stenosis also. So that way you can treat that thrombosis. How do differentiate between stenosis versus thrombosis? See, on ultrasound, you can see the thrombosis. When you see the thrombosis, for example, this is the vein, and this is the thrombosic segment, and there is a stenosis here. So this stenosis has caused the stasis of the blood. That's why it is stenosis, this thrombosed. So that means you have to correct this stenosis also. If you do the thrombectomy or open or the this endovascular thrombectomy, you remove the thrombus, it will again form. So you have to do thrombectomy with correction of the stenosis. Otherwise, there is a recurrence. Anything else?
Hope all our queries are sorted out. If
Okay,
there are
dear.
no more questions, then we can say thank you to sir.
Thank you. Thank you.
Thank you so much, sir. I think we were fortunate to have you speak on such an interesting topic, and we'll
Thank
be happy to have you again.
Yeah, sure, sure, sure.
And can we share the presentation with the students, sir?
Why not?
Sure, sir. Thank you so much, sir. Thank you. Good
Thank
night.
you, dear. Thank you. Thank you. Thank you.